I welcome Dr. MVS Satyapreakash sir, who is a professor. Sir has got a total of 35 publications and has written 6 chapters in 5 books. Over to you, sir.
I'll deal this session in the following subheadings: history, advantages, disadvantages, contraindications of Vats, pre-anesthetic assessment and preparation, intraoperative maintenance, physiology, and so on. At the end, a note on robotic assisted thoracoscopic surgeries and non-intubated video assisted thoracoscopic surgeries. When you think about history, the first thoracoscopy was done by a Swedish internist by name Hans Christian Jacobus. He did it by using a niche cystoscope. He first created artificial pneumothorax for the treatment of tuberculosis. In those days, in the early 1910s, the treatment of tuberculosis is by creating artificial pneumothorax. Once the medical management has started, this thoracoscopy gone into obsolete. But in early 90s, when the laparoscopic surgery started, with the advent of laparoscopic surgeries, this video assisted thoracoscopic surgeries also gained momentum. And as the science advanced by manufacturing small cameras, augmented light transmissions and all those things, this video assisted thoracoscopic surgeries have gained momentum. Video assisted thoracoscopic surgeries can be minimally invasive thoracic surgeries where there is a small hole is made and surgeon's hand is put inside to manipulate, then it is called as minimally invasive thoracic surgeries. And robotic assisted thoracic surgeries, the small hole may not be there, and in video assisted thoracic surgeries, pure video assisted thoracic surgeries, the small hole will not be there. So that is the difference between minimally invasive thoracic surgeries and video assisted thoracic surgeries and robotic assisted thoracic surgeries. The video assisted thoracic surgeries can be done in many procedures. It can be diagnostic, it can be therapeutic. Year on year, many procedures are being added to these Vats surgeries. What are the advantages of Vats? The advantages are, as there is a minimal surgical incision, it leads to consumption of less amount of analgesics and early recovery. Because of less amount of analgesics and minimal incision, minimal stimulation, because of our incisions, there is decreased morbidity and mortality compared to the big open procedure where morbidity is more, decreased days of hospital stay, decreased chances of shoulder dysfunction. Because there is very small incisions and small tubes are put inside the thorax, and there is no splinting of the ribs to put both the hands of the surgeon to do surgeries, the shoulder dysfunction is reduced. At the same time, there is decreased severity and complications of lung, decreased splinting of ribs. And what are the disadvantages of Vats? The disadvantages of Vats are high initial cost, longer learning curve, increased complications such as bleeding. In case if bleeding develops during intra-op, surgeon requires more time to control it, and anesthetist has to cope up with this increase in time to control the bleeding. And at the same time, when compared to open procedure, during this Vats procedure, there is insufflation of carbon dioxide into the thorax so that the manipulation of the tissues by the surgeon is more easy. So because insufflation of carbon dioxide is there, carbon dioxide can be absorbed, and all the problems of absorption of carbon dioxide has to be dealt by the anesthesiologist. And it is must for the anesthesiologist in the Vats surgeries to provide a good collapsed lung so that the surgeon can have a room for doing surgery. Rather than in open surgery, if you partially collapse also, surgeon can manage. But in a Vats surgery, it is must for a fully collapsed lung in the operated side. As there is insufflation of the carbon dioxide, there is compression on the mediastinum, which leads to change in the hemodynamics in Vats. which has to be dealt by the anesthesiologist. So what are the contraindications for Vats? Any procedure if you take, there will be contraindications. It can be absolute contraindication, it can be a relative contraindication. The absolute contraindication is when the patient is unable to tolerate one lung ventilation, then that is an absolute contraindication for Vats. What are the relative contraindications? The relative contraindications determine upon following conditions: previous surgery leading to adhesions, thereby collapse of the lung will be difficult, or there is creation of room for the surgery will be difficult, radiotherapy leading to formation of adhesions, extensive pleural disease, anatomical considerations for the surgeon such as central or endobronchial lesions where the equipment cannot reach through Vats, large tumors where it cannot be dealt with a small incision. In these conditions, Vats procedures are contraindicated. Now we will come to the pre-anesthetic assessment and preparation. As my previous speakers dealt, lung functions has to be done, lung function test has to be done before taking up the patient for Vats procedures. It can be bedside pulmonary functions or laboratory function tests. These lung functions should be optimized before taking up for surgery. And at the same time, when we are assessing for lung function test, we should assess in such a way that all the criteria for open procedure are also met. Because at any point of time, if the surgeon is unable to proceed because of any technical reason, or any complication happens and surgeon needs to open, we have to be ready for the open procedure. So the pre-anesthetic assessment should be online with the open procedure. At the same time, there will, as these patients, majority of these patients will be old age patients, they have more comorbid conditions. These associated comorbid conditions such as cardiac functions or any other liver functions or any other organ damage is there, those comorbid conditions should be treated and optimized. If the patient is on anticoagulants, these should be optimized or proper adjustments has to be made, as if we plan for any regional analgesia during the procedure or post-op procedure. And lung functions has to be improved, not preferred in these patients. Then what are the preoperative arrangements we should do in these patients? We have to do either lung isolation or lung suppression to provide one lung ventilation. Lung isolation means here, because of the condition of the lung, the non-diseased lung should not be contaminated with the secretions that are produced in the diseased lung where the operation is going to be done. This is, in these situations we have to do lung isolation. That means contamination is prevented from one lung to the other lung. What is meant by lung separation? Lung separation is, this is only for a separation of the ventilation, or collapse of one lung is provided. For that purpose only we are securing a different types of endotracheal tubes. Thereby it is easy for us to collapse one lung. There is no risk of contamination in these cases. This is called lung separation. If lung isolation is required, then it is better to be achieved with the W-lumen tube. If lung separation is required, any method is okay. How we can achieve this lung isolation and lung separation? There are many different tubes are there. One of it is W-lumen tube, where there are in W-lumen tube, 2 lumens are in a single endotracheal tube. There are 2 lumens. One lumen will open into the trachea, another lumen open into the bronchus. If it opens into the left bronchus, it is left W-lumen tube. If it opens into the right bronchus, right W-lumen tube. And this connector is connected to this W-lumen tube, and then it is being ventilated. If you want to collapse one lung, any one of the lumen can be blocked, and then we can provide one lung ventilation to these patients. What are the advantages in these W-lumen tubes? Because there are 2 lumens, we can do easily suctioning aspiration of the collapsed lung or suctioning of the ventilated lung if there are any secretions contaminated to prevent more contamination. We can introduce CPAP in the collapsed lung. We can, in case of any problem we encounter, we can rapidly convert into two lung ventilation in case of double lumen tubes. What are the disadvantages? As there is two lumens, each lumen is smaller when compared to a single lumen, so there is increased resistance to ventilation. And as it is a bigger size tube, it is difficult to secure, and at the same time in difficult intubation it is much more difficult to secure. As it is bigger size tube, more trauma to the airway can happen and more expertise is required to achieve double lumen tube in a proper position. Flexible fiber optic bronchoscope is required most of the times to confirm the position of the correct position of the double lumen tube, and even more it is difficult if we choose a right sized double lumen tube where the upper lobe opening is in the cuff of the right bronchial lumen. So it has to be aligned with the upper lobe bronchus of the right lung. So it is more difficult in the right sided double lumen tube. The other type of tubes which we can use are univent tubes, where there is a provision of small lumen through which we can use bronchial blockers. Thereby we can insert the bronchial blockers into a proper place where one lobe can be blocked and collapsed, or total lung can be blocked and collapsed. Here the lumen of the univent tube opens present in the trachea rather than in the bronchus. So what are the advantages of the univent tubes? These are less traumatic than the double lumen tube because these are smaller than the double lumen tubes. We can selectively block the required lobe and rather than a total lung. We can use same tube for postoperative elective ventilation rather than changing the double lumen tube to a single lumen if patient requires postoperative elective ventilation. We can achieve a secured airway even in difficult intubation patients in univent tube with univent tubes. It can be used in tracheostomized patients also. It can be used in pediatric patients also. As you have seen, double lumen tubes are available from 26 size only, so which are not so comfortable for pediatric patients, but these univent tubes are available in pediatric sizes also. What are the disadvantages? Choosing a proper size of the tube is difficult because if the bronchial blocker which we have the side channel, through the side channel when we secure, if that bronchial blocker is not sufficient size, we don't know whether it is sufficient size to block the entire lumen which we want to block. So that's why choosing a proper size is little bit difficult when compared to the double lumen tube. It can be easily slipped if once we block, after some time because of the regular ventilation and regular manipulation of the surgeon, it can be easily slipped and then one lung ventilation may be lost. The bronchial blockers that can be used through these univent tubes are Ant blocker, Fuji blocker, Cohen blocker, or we can use our regular endotracheal tubes by making endobronchial intubation and then give single lumen tube, which is very old technique. We have to do preoperative preparation for pain also depending upon the patient's psychology. If the patient psychology and physiology of the patient. If the patient is fit for thoracic epidural or blocks such as paravertebral block, serratus anterior block, erector spinae block, we can use them. Or patient controlled analgesia also, patient controlled regional analgesia, patient controlled IV analgesia also can be used. Preoxygenation is must in these patients because all these patients have deranged lung functions. So full preoxygenation is required, and at the same time we are using special tubes which require little bit more time for securing the airway. So preoxygenation has to be done properly. Induction and intubation depending upon the type of availability of type of gadgets which you are available, those type of endotracheal tubes you can choose. Induction drugs, depending upon your comorbid condition of the patient, we can choose the induction drugs. The monitoring that is required in these patients must are ECG, SpO2, urine output, temperature as usual. EtCO2 is must. Blood pressure, depending upon the comorbid conditions, either non-invasive blood pressure or invasive blood pressure can be chosen. Fluid status monitoring, depending upon the monitors which are available. Double lumen confirmation can be done once we secure the double lumen tube. Once we have to do fiber optic bronchoscopy, and then if we see a small bronchial cuff through the tracheal tube, then it is a optimal way of securing the double lumen tube. This is the carina at which we are seeing. Just above the carina, the tracheal lumen is opening, and at the same time bronchial cuff we are able to see, and it is completely occluding the lumen. So one lung ventilation. The main goal in one lung ventilation is to achieve adequate oxygenation and adequate ventilation. How we should achieve? Before achieving one lung ventilation, we have to first increase FiO2 to 1. Once we increase FiO2 to 1 for at least 3 to 5 minutes, all the nitrous and all the nitrogen which is present in the lung will be expelled out. Once it is fully expelled out by seeing the gas monitoring, then we can block the lung which needs to be collapsed. Once we block the lung which needs to be collapsed, then the tidal volume should be optimized to a level of 6 ml per kg. Once we make the tidal volume to 6 ml per kg and patient is being ventilated properly for some 3 to 5 minutes, then respiratory rate has to be adjusted such a way that the EtCO2 should be at around 35 to 45 mmHg. This is permissive hypercapnia level. If we can achieve respiratory rate around 16 to 20 and tidal volume is 6 ml per kg with EtCO2 of 35 to 45 mmHg, at the same time peak airway pressure is not more than 35 centimeters of water, with SpO2 is more than 92%, then one lung ventilation is properly achieved. If we are unable to achieve any of the parameter and SpO2 is dropping to less than 92%, then the following algorithm can be done. First, suction has to be done in the ventilated lung. Then introduce PEEP to the non-operated lung. If still patient is unable to maintain SpO2 more than 92%, next the tidal volume can be increased to 8 ml per kg. If each stage we have to wait 3 to 5 minutes. If we are unable to achieve the set parameters, then the next stage has to be proceeded. If still we are unable to achieve the set parameters, then consider change to pressure controlled ventilation, where peak airway pressure should not be more than 35 mmHg. If still we are unable to achieve the goal of EtCO2 and SpO2, then intermittent oxygen delivery to the operated lung has to be done. If still we are unable to achieve, you can introduce CPAP to the operated lung. If still we are unable to achieve, if you have the gadgets of high frequency ventilation, then we can introduce high frequency ventilation to the operated lung. If still we are unable to maintain the goals, then introduction of nitric oxide and prostacyclin vasodilators. If still we are unable to do, hasten the surgeon to ligate the pulmonary artery which is supplying to the surgical site. Then we can achieve the set goals. What is the physiology behind it? The physiology behind it is these surgeries are done in lateral position, and we are blocking the one lung or one lobe where ventilation is not being done but perfusion is being given. So there is a wasted ventilation or shunted perfusion. Even though the wasted ventilation is there, shunted perfusion is there, physiologically the shunt will be minimized because of the gravity and because of hypoxic pulmonary vasoconstriction. If these are not sufficient physiologically, then hypoxic pulmonary vasoconstriction can be optimized or aggravated by converting inhalational maintenance to intravenous maintenance or introduction of vasodilators such as nitric oxide or PEEP. How PEEP will decrease the shunted perfusion or wasted perfusion. It decreases the shunted perfusion, wasted perfusion by increasing the FRC if we introduce PEEP to the non-operated lung. But this introduction of PEEP is detrimental in some patients where there is already auto PEEP is there. If auto PEEP is there, if we introduce PEEP, there will be increased in pulmonary vascular resistance, which increases the wasted perfusion or shunted perfusion. Now, if there is non-collapse, one more complication which we get is non-collapse of the operated lung. This can be followed by, this can be optimized by following up protocol. First, check the completeness of blockade by doing fiber optic bronchoscopy. Then try to increase FiO2 to 1, thereby eliminating all the nitrogen in the non-dependent lung, means the operated lung. Opening of the non-ventilated lung to the atmosphere, or suctioning of the secretions in both lungs by bronchoscopy, or redo bronchoscopy and readjust the position of the DLT, or ask the surgeon to compress the lung which he wants to operate by opening up it to the atmosphere by insufflating the carbon dioxide. Fluid management, restrictive fluid management strategy is preferred in these patients to prevent seepage and pulmonary edema. If dynamic fluid indicators are present such as systolic pressure variation, stroke volume variation, delta pulse pressure, then goal directed fluid therapy is better. These patients, if blood loss is there, proper replacement of blood loss has to be done. Intraoperative technical consideration, regularly surgeon asks here to do Valsalva maneuver to check whether there is completeness of their bronchial suture ligature is there or not. So repeated Valsalva maneuvers may create problem in maintaining hemodynamics. In a hybrid theatre, the surgeon may secure a clip at the lesion. For this procedure, we need to give apnea to this complete apnea in these situations. So during that procedure, maintaining oxygenation and ventilation is by the anesthesiologist. Once the vascular ligature is completed, surgeon will ask us to check the completeness. Bronchial ligature and lung expansion has to be done by us, and at the same time we have to do bronchoscopy, check the completeness of the ligature of the bronchial lumen, and at the same time whether there is any leak is there or not by bronchoscopy. Patient has to be turned supine and then do good suctioning so that no blood material present in the trachea or bronchial lumens, because these will stimulate and cause bronchospasm or laryngospasm. Awake extubation is preferred. Elective ventilation, if it is required, change it to the regular ET tube. And post-operatively, PCA or patient control analgesia, PCRA is preferred. Post-operatively, monitoring of oxygen and ventilation has to be done, because these patients have lost one part of the lung or part of the area where there is ventilation and perfusion was being done. The differences between robotic surgery and Vats is, as there is a docking of the robot, once the robot is docked, there is a minimal space for us to enter into near the patient. So it is better to secure, space constraints are there, better to secure DLT rather than in-event tubes or blocks, because in case one lung ventilation is not done properly, the surgeon cannot operate. Hypercapnia chances, and patient should not move in these patients, in these surgeries, because once the robot is docked, movement of the patient is hazardous to the patient, and emergency protocols has to be preoperatively properly rehearsed before positioning for the patient, because we are unable to reach to the place in proper time. A note on non-intubated Vats. Advantages are complications of general anesthesia, polypharmacy can be avoided, potential benefits of regional anesthesia can be done. The disadvantages are because we can't provide one lung ventilation in these patients, very few procedures can be done. As patient is fully awake, different position needs to be attained in these procedures. Shorter surgeries only can be done. We can't convert immediately if there is any problem during the procedure, because patient is not in a supine position and special tubes are required. Contraindications to non-intubated Vats are hemodynamic instable patient, morbid obesity patients, inability to cooperate patient, difficult airway patients. What are the types of procedures we can do in non-intubated Vats? Non-intubated Vats, the main blocks are thoracic epidural, paravertebral blocks. Supplemental blocks are serratus anterior block, interpleural block, local wound infiltration, and supplementation with dexmedetomidine, propofol also can be done. Opiates are not preferred in these patients due to respiratory depressive effects. These are my references. Thank you.